which would have also participated, put together the Presidential Health Summit. So maybe to kickstart, invite them to join Dr. Motsoaledi in the panel. Dr. Angelique Kutsia, she represents health professionals. I'm not sure if Dr. Kutsia is here. Thank you, ma'am. Yes, please. Ms. Tanya Cohen, representing Business Unity South Africa. Mr. Mabalane Mfundisi, representing civil society. Dr. Kalu Akbar, representing the World Health Organization. And Mr. Daniel Manamela, representing Denosa. I'm not sure if Mr. Manamela is here. Okay, I'm sure he'll be joining us. Let's put it on the record that there's an apology. Okay. I want to put it on the record. I'm very sensitive of labor. Are you here? Could I invite ma'am to take Mr. Namela's seat? Thank you. Thank you very much, colleagues, and also to acknowledge the presence of the President's Social Policy Advisor, Dr. Olive Shisane, sitting on my left here. So as you know, the Presidential Health Summit was held in October last year with the objective to work towards an integrated and united health service. So without wasting any time, I'm going to invite the Minister of Health, Dr. Aaron Motsoaledi, to deliver on behalf of the President his remarks at this launch. Dr. Motsoaledi.
Thank you very much. Let me just say, fellow panelists, in order to save time in the true African tradition of protocol observed. Ladies and gentlemen, I'm sure Kusel has already told you that I'm representing the President, who up until this morning still thought he would make it. So I'm not reading a speech on behalf of the President, I'm reading the President's speech, which means for the next few minutes, just pretend I'm the President. When I keep on saying I, it's never going to happen, but just present that for the few minutes, because the speech actually starts by acknowledging the Minister of Health. So yes, it says Minister of Health, Dr. Aaron Motsoaledi, the World Health Organization country representative, Dr. Kalu, representatives of other stakeholders in this meeting, ladies and gentlemen. It's a very special moment for me to join all of you for the launch of the report on the Presidential Health Summit 2018. The summit took place in Ekurhuleni on the 19th and 20th October 2018 under the leadership of the Deputy President David Mabuza, who officiated in my absence. The theme of the summit was strengthening the South African health system towards an integrated and unified health system. This theme reflects the commitment in the National Development Plan to a sustainable quality health system that provides equal access and care for all South Africans. The Presidential Health Summit 2018 gave us an opportunity to examine our national health system as a patient in its own right and to arrive at the diagnosis that will allow us to intervene and return this system to good health. The Health Summit was able to give detailed attention to many of the issues which I had been presented by various individuals and stakeholders since becoming president at the beginning of last year. Many people have raised concerns and complaints with me about the poor quality of healthcare that people experience in our clinics and hospitals during their moments of vulnerability. Complaints include inadequate access to medicines and equipment, inadequate number of staff in our facilities, unprofessional conduct of staff, labor unrest, corruption, and theft of hospital property. South Africa South Africans also complain of poor delivery of mental health services and delays in accessing health care. One of the barriers to access is the unsustainably high cost of private health care. Many users of this care experience above increases in medical scheme contributions and the failure of medical schemes to pay for patient services that have been rendered. Several organizations have raised concerns with me regarding the dysfunction of the health system, to the point that it's clear that the system is in crisis and needs urgent rehabilitation. These are issues that must be addressed collectively by all stakeholders if we are to prevent a collapse of the health system. We need a robust, efficient and caring health system in our country, where more than 7 million people live with HIV, where we are seeing a rising rates of diabetes, hypertension and cancer, and where maternal and neonatal death rate must be reduced. Too many people do not receive quality preventative, promotive, curative and rehabilitative healthcare services. As we itemize the challenges we face, we are encouraged by gains we have made during 25 years of democracy in building a healthier nation. According to the Medical Research Council's Rapid Mortality Surveillance Report 2017, which was released a few days ago, average life expectancy in South Africa increased from 61.2 years to 64.2 years in the 5 years between 2012 and 2017. The survey also recorded decline in mortality among children under the age of 5 and among infants. Neonatal mortality was unchanged during this 5-year period, while maternal mortality declined by more than 30%. In 2009, South Africa became the first country in Africa to introduce pneumococcal and rotavirus vaccines. 5 years later, the South African Medical Journal reported a 64% reduction in rotavirus diarrhea hospitalization and a 46% reduction in hospitalization for invasive pneumococcal disease in HIV-negative children older than 16 years of age. While we've made much progress, there is much more that needs to be done. Our efforts to restore our health system are informed by 2 of the 5 national priority tasks I outlined in the State of the Nation address just a few days ago. One of the tasks is to improve the conditions of life for all South Africans, especially the poor. The other is to strengthen the capacity of the state to address the needs of the people. I indicated in the State of the Nation address that in 2019 we'll take a significant step towards universal health coverage that will bring quality health care to all South Africans. After extensive consultation, the NHI bill will soon be ready for submission to Parliament. The NHI will enable South Africans to receive free health service at the point of care in public and private quality accredited health facilities. The NHI delivery model will be based on primary health care approach, which emphasizes the importance of providing preventative, promotive, curative, promotive, and rehabilitative services. By applying the principle of social solidarity and cross-subsidization, we aim to reduce inequality in access to health care. Realizing the magnitude of the challenges in health care, we have established an NHI and Quality Improvement War Room in the Presidency. This war room brings together various key departments to address the crisis in public health system while preparing the implementation of NHI. We are guided by the insight that improving the health system and introducing NHI are 2 sides of the same coin and are mutually reinforcing. Repairing our national health system is an endeavor that requires the input, involvement, and innovation of all role players who understand that good health makes for a good life and a good economy. At the time when we are laying the foundation of increased investment in our economy and we are developing the skills of our people to be active in the economy, it is essential that we build and maintain a healthy nation. This is not a responsibility that rests only on the shoulders of the delegates of partners of the Presidential Health Summit 2018. This is a responsibility that must be exercised by all South Africans who are called upon to adopt a healthy and active lifestyle and to take care of their physical and mental well-being. Our measure of success should not be rising levels of treatment for highly preventative conditions, but it should be the reduction of incidence of such conditions in our society. The summit adopted the principle of one country, one health system, and welcomes the renewed energy and commitment within government to improve the health system. The summit generated unanimous support for national health insurance and for the principles of universal quality health coverage, social solidarity, and equity in health access. The NHI aims to embed the principle that healthcare services will be based on clinical need and not on ability to pay. Healthcare will therefore be free at the point of service. The summit proposed a centralized national procurement system which will achieve economies of scale and assist in addressing corruption. The success of a quality health system rests on information systems that can generate valid information at the right time and in the right format for decision-making and monitoring at all levels of management, taking into account the need of patient confidentiality. Having identified critical challenges, the summit called on government to urgently prioritize the filling of critical vacant posts. The summit tasked the National Treasury to develop a sustainable financing model and urged provinces to prioritize their financial resources allocation to ensure the delivery of quality health care is not compromised. Further proposals relate to the development of expertise and funding to implement government's health infrastructure plan in a manner that will respond to changing populations and clinical dynamics. This demands stronger coordination between the Department of Health and partners, such as the Department of Public Works. Overall infrastructure in both the public and private healthcare sectors must meet the requirements of the Office of Health Standard Compliance. The summit acknowledged the critical role the private sector has to play in the realization of universal health coverage and the vision of NHI, and called for inclusive process starting through the summit to continue. Most importantly, healthcare users need to be actively engaged in the process of unifying the health system, and community health workers need to serve as a vital link between communities and health facilities. The summit derives its historical importance from the fact that this was the first that such a rich diversity of stakeholders and collectively confronted long-standing challenges in health and collectively devised measures that will overcome these challenges. Through the inclusive
and so we come out of that address by Aaron Motsoaledi, the health minister. He's addressing on behalf of the president, who's
inclusive engagement can make a great difference in the quality of life of South Africans. The summit has underlined once more the benefit of working together as a nation and building greater understanding through the involvement of a wide range of persuasions and expertise. The report we are launching today serves the dual purpose of documenting the summit deliberations for the purpose of setting implementation in motion. At the same time, it provides guidance to the many millions of South Africans who could not attend the summit and who, in the spirit of Tumamina, wish to know what role they can play in the health revolution. Representatives of the summit sectors are currently developing a presidential health summit compact based on the outcomes, which commit sectors to work together to implement identified solutions. The initial sectors identified are government, civil society, labor, health service users, business, private providers, funders, statutory councils, academia, health professionals, and allied health workers. Representatives will consult their key constituencies on the interventions to be implemented and craft a plan that includes clear objectives, methods, timelines, indicators, and financial resources. I call on all South Africans to study this report with a better future in mind and to identify ways in which we can reach the outcomes of the summit and set our nation on the road to good and sustainable health. I wish to thank Deputy President David Mabuza, the Minister of Health, Dr. Aaron Motsoaledi, my Special Advisor on Social Policy, Dr. Olive Shisana, and the conveners of the Presidential Health Summit 2018 for creating a platform from which we will launch quality and universal coverage that will benefit our entire nation. I wish to thank all the participants for their contributions in the robust debate and constructive outcomes. Lastly, I wish to thank the media for covering and commenting on our transformation of the national health system. Information is a vital part of empowering citizens and to contribute to and benefit from the changes that we are realizing in our country. The Presidential Health Summit 2018 has generated a wealth of ideas. Now, we must act on these ideas and to act together ensure effective implementation. There's a great deal of work ahead, but if we proceed in the spirit and with the determination with which we have started, I'm certain that will succeed. Thank you.
Thank you very much, Your Excellency, Mr. President. Thank you, Minister. Colleagues, that is the statement as delivered by Minister Motsoaledi on behalf of the President. I will take any questions from the media, and I would invite the panelists to support Dr. Motsoaledi in responding. Ma'am, there's a roving microphone somewhere. If you could introduce yourself, please.
Good afternoon, I'm Tamar Khan from Business Day newspaper. I suppose I should say sir, because I'm not sure if I should say president or minister. Could you please, first of all, give us an update on the status of the NHI bill? Has it been approved by Cabinet? And if so, when is it going to Parliament? If not, why not? And linked to that, shortly after the Presidential Health Summit, several players involved in the process voiced disquiet at the way they felt the summit was being misrepresented. They claim that in no way did the gathering give an endorsement of NHI, and that it wasn't on the agenda, and it wasn't discussed, and it wasn't put to a vote. But those comments have been made again today. Could you please explain the discrepancy between what some critics are saying and what you've said today?
Thank you. Can I take 3 questions in this round and then I'll come back for the last one? Do we have any other question, Amo? Okay, it seems to be clear, or we're waiting for a brainwave. All right, if you could pass the microphone to the Minister, please.
Well, Tama, our approach has been that when everything is done and dusted about NHI and it's going to Parliament, we'll make that announcement when that time comes. You just have to be very patient. That's what we've always been doing with most of the bills. I'm not sure why people want to believe that NHI must follow a different path altogether. The second question about the gathering that did not support NHI and there was no vote on the issue. That summit was not called for people to vote at all. And there's no question about voting. I attended that summit. The debate was not whether NHI must happen or not. Of course, there are those who are against it. The debate was from many people who were worried, and I still hear that, is that they believe we are not ready, we need to improve the public healthcare system first before we come to NHI. That's what I'm hearing. All critics or people who criticize NHI, they start by saying we support it, but, and the but is about the improvement of the healthcare system. Now, if I must respond, we reject that view in totality, because at no stage of any nation will anybody ever stand up and say the public healthcare system has finally been adequately improved and we stop here, we go somewhere. It's a lifelong thing. Nobody can stand up, even in advanced economies, nobody can stand up and say we have successfully improved the healthcare system, we are now studying the next step. I made an example here of the UK, who started universal health coverage 70 years ago, immediately after war, 3 years after war. At that time, the healthcare system in Britain did not exist. If you followed the debate, it was not existent because Britain was battered by the Second World War. In fact, I was informed that Britain at that time was on the brink of bankruptcy when they introduced universal health coverage. And even up to today, they are still improving the healthcare system. They are still recruiting doctors from us. They are still changing the way they do things. They've never stopped in a period of 70 years. So anybody who says we must pause first and start. And lastly, I just want to remind you, much as we have got problems with our HIV/AIDS program in terms of overcrowding and all that, running the biggest program on earth, I want to remind you that if you go back to 2009, when we had only 923,000 people on ARVs, every time we announced a further step to increase them, people told us the same thing. No, but the healthcare system is not ready. Please sit back and improve it first. You are going to add more people. Even now we've announced that we're adding 2 million people. They said, no, but how can you do it in a healthcare system that is not ready? Imagine if we listen to that and not put people on ARVs. What could have happened to the healthcare system? Actually, it will have collapsed. With people dying on beds, having pneumonia, meningitis, and all sorts of diseases that we are no longer seeing. That would have been a collapse if you kept on waiting. So we rejected that. We continued. You solve the problems as they occur. And we think we'll do the same about NHI. Thank you.
Thank you very much, Minister. Are there any other questions? Ma'am, I've noted you. I'll give an opportunity again. Oh, sorry, you want to add, sir?
Yes.
Thank you.
I think, I come from the community sector. Having attended the summit, and other colleagues will attest, although it was not about the NHI, but the majority of the engagements in the various commissions, and there were 9 of them, were about how do we fix, and as we move along, to introduce the NHI as our collective response to universal health coverage. Because what must also be understood is not to elevate some of the voices at the expense of the others. Because the other voices, the ones that we come from, indicate that we also want to see, a change in terms of what has been put in place. So there must also be, a balanced approach towards the different views. Of course, there are those who have a view that we should wait until everything is sorted. But there is equally an important voice that says we need to fix as we move along. And this must not be used as a football match to determine who is the winner. The winner is South Africa achieving what is in the Constitution, and that is in Section 27, that there must be provision of quality healthcare for all and not for some.
Thank you very much, Mr. Mabalane. I've got 3 questions. The ladies, where's the microphone? Okay,
Dr. Motsoaledi. I'm Nadine Theron from ENCA and ENIS. I want to ask you, is there any more clarity about what will medical schemes be able to cover and what will have to be covered by the NHI? I know there was a leaked document saying that certain things medical scheme will not be allowed to cover certain things. That's my first question. And my second question is, was the mental health high on the priority list at this debate? Since we've had the life is the many tragedies, was there an emphasis on how the NHI will also assist people with mental health care?
When you say in the debate, you mean at the summit?
Oh, sorry, yeah, at the summit.
Hello, Dr. Motsoaledi. I'm from Netwerk 24, Nelly Brandt. Netwerk 24, die Burgerbeeld and Volksblad, and my name is Nelly Brandt-Jonker. So I came here today because I thought in the press release I said the President will report on the proposed solutions that the 9 summit commissions developed. So obviously the solutions haven't been developed. So I want to know, do you have a time frame? When will we see the solutions? Will it be another report? And in the meantime, the 9 commissions are being paid to. What has the cost been in the past 4 or 5 months that they've done their work already? Can you give us an estimate of what it cost? The commissions, the 9 commissions that's doing this work, how much does it cost to do the work?
Hi, Anse Tom from Spotlight. I heard the community representatives speak about civil society representing community, so I see different representatives. I'm just interested to know what happens next, because I'm sure there's a doctor representing health professions, and I'm sure everybody's not singing from the same songbook, as the minister alluded. So what's the process from here to get all the voices to still be heard? Because not everybody's going to have the same approach, the same thoughts about the way forward. And I'm specifically also interested in the community representative in DENOSA, is how do you bring your people on board? And yeah.
I'm sure I'm not the only one who's going to answer the question. We've got the whole panel here. I'm not sure whether any of the panelists would like to start. Because I started first.
I'll start second, and then I'll give it to my colleague next to me. And to answer the question, the one question something that we need to make clear is the Presidential Health Summit is not NHI. It's how to get the groundwork in place for a future NHI. So it is a bit, if people keep on asking about NHI, you're missing the point. The point is not NHI here. NHI will be the end where you want to go to. So to get there, you first need to get the building blocks right. Second thing is very important, that the 9 commissions have not been paid anything. We have done this work for free. So there is no cost involved in this. On the medical side, to get doctors involved, it's not only the doctors, it's all the different allied groupings as well. Currently, we have about 130 different groups under us or working with us. We are only convening all these meetings. And yes, it is difficult. And I've never expected 130 different organizations under one umbrella to all come and sing from the same book. That will be a first. So yes, you have an opinion, and you don't need to agree with what the Presidential Health Summit is doing, but you can stay behind. You know, a few years ago, when NHI has been introduced, we were told that the train already left the station. You can either stay at the station or you can be part of the train. And we from the medical profession, we had to get onto the train and take this journey, because otherwise, if you stay on the platform, you will never be able to influence anything going forward.
Thanks. see at the summit when the resolution or the key issues that were agreed, one of the slides said that by the 10th of December, we're going to come and outline what it is that we have committed to in the compact. That was not the case, and it's because as a former president and former chairperson of South African National AIDS Council, Kgalema Motlanthe used to say, to embrace the concept of hurrying up slowly. That process necessitated that while some of us may have wanted to ram through what we would have believed are resolutions, we needed to take into account that we need to bring everybody along and everybody on board. As Dr. Kutsi has indicated, it has not been an easy process, and it continues not to be an easy process. From the community perspective or civil society, various voices form part of the collective. One of the voices, and we come from organized civil society under the banner of the South African National AIDS Council, SANAC. We have 18 sectors, one of which is the people living with HIV. But one of the stakeholders in this summit is public health users. And the PLHIV is a central and leading part of it. But it includes others, because the health ailments are not just about HIV. It also includes others. And it was and continues to be a very difficult process to bring people who are on various sides of the coin together, because what brings all of us is to ensure that there is health, quality health that we all enjoy. And we will continue on that particular path to ensure that we bring people up, along and on board. One of the stakeholders that forms part of a civil society is the traditional health practitioners. And there was a realization that traditional health practitioners and allied health professionals need to come together, and space was created to ensure that we don't leave anybody behind, and ensure that as we move along towards developing the various compacts, and we have worked on that process as the civil society grouping, including being encouraged by other stakeholders who are working around it to ensure that they bring everybody along on board. And we left that concept of the 10th of December as the cut-off point, and Professor Shisana here was not a happy person, but she had to march along, because was her key performance area was to ensure that what was announced in the summit in October resulted in a compact on the 10th. It was not possible, but with the timelines we have, we are sure and clear that all of us would have done adequate consultation, and they may not be for everybody and everything, but when we come together and announce what our different contributions are. And Dr. Kutsi, we actually, the commission is not paying any cent. We're actually paying, even coming here, there's no government money that has been used. All of us as different organizations had to use the resources that we have from where we come from in terms of being part to this. Because we also don't want to be captured by, using government's money. We are contributors, we are participants, and we see this. So it has actually cost us money to take the journey forward, rather than money being used on us in terms of the beginning of the end. The summit was the beginning of the end. We are now in that journey.
So I would just want to add, and particularly about the process that we're busy with. So I come from the business constituency, and I think that certainly when we started this process, there was a lot of contestation in terms of what is the summit about. And I think that we did find each other as social partners in terms of coming together, having a common understanding as to what are the challenges in the public healthcare system. And I think the summit, what it did was that it surfaced a number of the challenges and potential solutions that are on the table. The process that we have agreed upon in the steering committee is that we submitted our input to the draft compact and the action plan by the 30th of January. And we're now in a process where each of those commissions, there are representatives from each of the stakeholders that will be meeting and identifying the action plan on each of those commission areas. and then we will be pulling that together into a compact. We have given ourselves a little bit more time to do this properly because we believe that it is really important that we work together as social partners in terms of finding solutions that we can all support and that we can actually all action. So I think what is really important in the process that we followed is that we're looking for tangible, action-orientated outcomes. We've gone beyond, I think, what is purely aspirational and what we all want, which is a much stronger healthcare system for the country that actually delivers to patient needs. And I think what we're trying to do is put that into tangible actions. The one point I think that is worth making is that what we haven't done is engaged on the legislation that is before NEDLAC and will be coming before Parliament and will follow the normal course. We have been focusing on the crisis. Thank you.
Sorry, ma'am, I'm sorry to interrupt you. Can I please request that you introduce yourself? Unfortunately, I didn't have your name.
My name is Gidiboni Dolo from Dinosa. It's just an addition, especially because there was a question specifically for Dinosa. And as an organization, we are part of this, driven more than anything by the objectives of the summit. And the process which we have taken as an organization, we are busy consulting our members. We had provincial congresses, and in March we'll be having our national congress. And within the National Congress, that's where we'll be having our plan of action on how, as an organization, in addition to be part of the alliance with other professional organizations, on how are we going to make sure, firstly, we know that our organization members are nurses, and it's one part where the health system or our community is not happy with. So as an organization, we'll make sure that our plan, firstly, there's mind change, that we become catalysts and be part of making sure that the health system works. So we commit ourselves, and we know that after the National Congress, we'll be having a way forward as an organization. Thanks.
No, I started with them. I still have my chance because I was, yes. I just want to add, Dr. Gutsie here from next to me from SAM said something impactful about the train leaving you in the station. Yeah, I want to expatiate on that because I'm not really threatening people. In January, I accompanied the president to Davos. Now, many people don't know that the World Economic Forum has been there for more than 40 years. And at no stage was a Minister of Health ever allowed in Davos. The first time we were allowed was in 2015, because the world is turning around in a revolution. The reason that we were invited to Davos was the realization that there is no economy anywhere in the world that will ever grow without improvements in health. It was the first realization. And it didn't come by accident. It's because the world is getting scared of having neglected health for a long time. What scared them? If you remember, there was an outbreak of Ebola in 2014. At that time, the economy of Sierra Leone was growing at 14%. Of course, from a lower base, but 14% is phenomenal. It took 9 months of Ebola, a virus, to bring it down to negative growth. Within 9 months, it was down. And there are some experts that say it might take 2 decades or so to take it back to where it was. So there's this fear that if healthcare is not taken care of, especially in the financing thereof, many economies might actually be down on their knees. So this year in Davos, all the sessions I attended were talking about universal health coverage and improve it. A special task team has been selected to work towards taking it to head of state meeting, high-level meeting, what they call high-level meeting in New York. It's going there in September. That the matter is elevated out of the hands of ministers to the heads of states themselves. And that's going to happen in September. Over the weekend, I'm sure you might have read snipers about that, in AU. There was a special session on the first day on the day before the opening, that is on Saturday, which I attended, African Leadership Meeting, Investing in Health. The president was invited there to speak specifically about NHI, specifically. Unfortunately, he was in demand. Well, if I may divert, I've never seen one human being that is in so much demand. I don't wish to be him. He was wanted left, right, and center as a president of South Africa. So he couldn't make it to this session. He asked me to go. I couldn't even speak because it was heads of states, the Secretary General of United Nations, and heads of agencies of United Nations, of course, with Mr. Bill Gates. Don't ask me why he was there because, as you know, he's one of the biggest funders of health. And now I was not allowed. They said, look, Chief, protocol doesn't allow you. This is very high-powered, you know. And so I could speak at that high-powered thing. And let me tell you what transpired there. Heads of state made it clear that all the time they've been regarding health as a social expenditure. Now they realize it's not like that. It's part and parcel of economic growth of any country. Any country that wants to grow their economy must finance, improve and finance their healthcare system. That was what heads of state has said. And now let me just read to you, because thereafter there was a call to action. Just like we did at the summit, no voting, just a call to action. And it's a very long document. I won't read all of it. I'm just reading one part of it. We commit ourselves to the following actions. And I'm reading action number 6. Enhance national health financing systems, including by exploring options to reduce fragmentation, exploring national health insurance where appropriate, strengthening capacities to purchase services effectively, and improving efforts to improve prevention, cost effectiveness, and allocative efficiency. Now, it goes on at number 15 to say we call upon ministers of health and finance to report annually to the African Union Assembly on country progress against the indicators on the African scorecard on domestic financing for health using the progress tracker tool. Now, the AU is moving, the United Nations is moving, and the Davos is moving, the World Economic Forum. All of them is about universal health coverage. And there is something they've got in mind. If we don't do it, one day the world is going to perish on the altar of inefficiency of healthcare services. So we can't keep on pondering here about whether we must do it or not. The world is moving, we'll be left at the station as South Africans. Thank you.
Thank you, Minister. I think doctors are trained to scare us. Minister, there's just 2 questions that I think we didn't respond to, the issue of the medical aid as well as mental health. I'm not sure if the Minister also just wants to maybe be a little bit more concise on the solutions that we would have come up with. You do have the reports there. I'll come back to you, ma'am. You do have the reports in front of you, but if the Minister could please just speak to some of those issues.
Yeah, okay, I'm sorry about that. Yeah, let's start with mental health. It was not a topic in itself, but part and parcel of the improvement of healthcare. But to put the issue of mental health in perspective, anywhere in the world, when a healthcare system is not adequately funded and there are fewer resources, one of the areas that will suffer is mental health. And that's why the WHO in 2013 called this conference on mental health and drew a plan, because you use all the resources only when something is left to think about mental health. Now we are going to try and change that, and we are aware of the weaknesses. But the summit did not necessarily put it as a topic more than all the others. It was part and parcel of improving the healthcare system and its financing. The issue of proposed solutions, I thought it was answered, if I'm not mistaken, by Mabalani, that in the compact, which is still going on, where we are still waiting for people to give their inputs, that's where solutions are, because we did not want to devise a government solution. We wanted each partner to come with a solution and say, we, in this sector, this is what will contribute as a solution. And that's why we're waiting. The state will also come with it. At the moment, as we're talking, I have sent a letter to all MECs to countersign the solution to be given by the state, because I'm going to sign on behalf. At the moment, the one solution that was there from provinces was done by HODs, but I want political heads to commit themselves. So I sent it back and said, no, this one is from HODs. I want the one from you as MECs, as political heads, to commit yourselves. Because I don't want to sign, and then in future they come and say, no, it was not me, it was my HOD. I want the commitment from them. So all these sectors, that's why DINOSA is saying they are going to conferences. So that is not only one leader who commits, but it's the whole sector. So that's where the solutions will be. We have got an idea of our solutions at the state, but you don't want to impose them, but you don't believe state solutions alone will help. The cost, I think the question has already been answered, and the issue of the civil society not having the same approach. The issue of what will medical schemes be doing, and leaked documents and all that, I think let me not respond to leaked documents, please. I'm not sure that document leaked from where and it says what, but the issue of medical schemes, NHI, are all in the bills. You are aware that the medical schemes amendment bill, we've put it in abeyance, waiting for the health market inquiry, because a lot of proposals there of health market inquiry will go in the bill. So we thought there's no point, and it's a pity that the health market inquiry delayed. But all their proposals, because we saw it in the initial proposals, will have to go into that bill. It's then that these questions that we have asked will actually be answered. Thank you.
Thank you, Minister. I'm taking my last question. I think there was a lady who had her hand up. Okay, the two ladies then. I'll start with you, ma'am, at the back.
Thank you. My name is Angela Drescher. I'm a consumer activist for healthcare, both in the private and the public sector. My question is the issue of dumping by medical aids and hospitals of private patients with private healthcare onto the public healthcare system. It's happening in 3 specific areas that I've been dealing with now for about 18 months. One of the biggest issues is the government employees pension fund, where there are currently about 9,500 pensioners who've lost the continuation of their medical aid, their state subsidized medical aid, because their pension fund has not been finalized. These are people with GEMS. Some more esteemed state employees, they get a moratorium with full health cover. So at the moment, there are a lot of state pensioners and people who are medically boarded who have now had to fall on the public healthcare system, despite having contributed to medical aids for 25, 30 years. And that's absolutely unacceptable. I have been speaking, I've got a meeting, or meetings lined up about this, but it doesn't seem like there's really a will to do anything. It's also happening in emergency rooms all around the country, where people with medical aids present at hospitals and they don't have cash. They are then also dumped into the public ERs, which are already filled with enough people from the public healthcare system. And the private healthcare users should not be taking those beds that I believe belong to the people who cannot afford medical aid. And then the final one is where provinces are signing designated service provider agreements with medical aids to nominate the state as the designated service provider. I don't find it an issue with the lower echelons of medical aids, the entry-level medical aids, but on the upper-level medical aids, I find that absolutely unacceptable. When you have 28 adolescent mental health beds in Cape Town, the whole of the Western Cape, and some of those are being taken by people who pay for private health care. That's absolutely unacceptable. Thank you.
Thank you, everyone. There are a few things, it's not questions, but it's comments. Some which will be additions. One, it's about the unity. Oh, sorry, my name is Dr. Mpopowe. The important thing that Dr. Mpopowe from the South African Medical Association, the trade union part. Thank you. The important thing that we have to acknowledge is that the health summit was not only about individuals. It was not only about the health workers, but it was about the South African as a whole. The people who are using the public sector, including the private sector. That is very important that the community has to understand. Yes, we are aware that in the public sector there's trouble. There's issues of human resource, there's issues of security, there's issues of overcrowding. But that's when you brought other factors where you'll bring the civil society who have to teach the public about how everything is functioning, what's happening in there. Yes, the psychological mental problems, not only in the community. Mental problem even goes as far as the health workers themselves. Being in private, being in public. I can give an example that just last year we had about 14 doctors who committed suicide. And it's not that there are financial problems or whatever, it's because of issues in the health that they're taking everything, you know, from the community and themselves, and they don't have life, literally. And in that, when you look at labor issues, it's not only the health sector labor which was involved in this. Labor was involved as a whole, from mine workers to professionals, to doctors, to engineers, and everyone. Documents are being circulated and discussed by all the labor members. In COSATU, they are discussed, and documents, inputs are being sent to the task team to actually have their voice heard in that. The last thing that I would want to, no, I think she covered me with that one. So I'll just leave it there. Thank you.
Thank you. Can we also welcome the Deputy Minister of Health, Joe Paisla? You're welcome, sir. Minister?
Yes. Angela, you know, is it Angel or Angela? Angela. Yes, Angela. Everything that you have said has been presented to former Chief Justice Mwago during the market inquiry. These are the complaints that people came up with. In the public healthcare system, we live with this every day, where a person is in coma in the ICU, and they phone you to tell you that no, the medical aid benefits are exhausted. The public healthcare system must take over. We do that. It's a weakness of our laws because it should not be allowed. I was told that in countries like the US, it's not allowed. I'm not sure I was going to explore that nobody running private health care can treat a person and before the treatment has been finalized, completed, to say. And after they've taken a huge chunk of your money and discharge you and send you elsewhere, it's not allowed. Once you start, you must finish the job, even when the money is finished. That is the weakness that South Africa does not have an act that stops that. And we believe in the NHI and in the Medical Schemes Amendment Bill. These are some of the things that we are going to stop. And that's why we need changes. Now, I'm not sure whether Chief Justice Mwago is going to make a finding about it. But I was there when most of the presentations were made. If I'm not mistaken, you made it. Yes, I remember you. The second day of the first day, yes, of the commission, which was held at the CSIR. I remember you very well. And it was because something happened in your family that forced you to get to get interested in this because you suffered as a citizen. And we are hoping the judge listened to you. We are hoping he will make some changes. If he hadn't in the bills, who will make the changes at the state? Because we have had you and we've been suffering from this. I would like to close with one example. I'm not losing the meeting. These issues we are discussing. As you know, I take my treatment at Steve Biko Academic Hospital. My cardiologist, Professor Sakin, who was the chairperson of the Cardiology Society, one day phoned me in distress. He said, Minister, I'm aware that I've got to accept people from the private sector who don't have money to pay. But some of these things must not be allowed. I said, what happened? He told me of a private hospital nearby, I'm not going to name it, where the domestic worker came with a heart attack. And they examined her, and they discovered that, yes, it's a heart attack. And they have to give, I nearly said anxiolytics, man. It's not anxiolytics, it's what lytics, the blood.
Trust me, we won't.
Yes. I haven't been practicing for quite some time. And Professor Sakin said, I said, okay, bring her over, but she's not going to make it because it will be too late. You have to give this lytic, yes. Yes, I don't know the name. I forgot, yes. And he said, please give it. I'll wake up from home, go to Steve Biko to wait for this patient. And the patient arrived there dead because they never gave it. And when he phoned them, they said, no, she's a domestic worker. Who was going to pay? This is the experience of every day, which people experience every day. Yes. He said, no, but who was going to pay? This is a very expensive treatment, and there's no way that the domestic worker will afford it. Now, if you have to die because your name is domestic worker, that cannot be civilization. And he was very angry with me. The second example, I think it happened about 5 or 7 years ago. An employer found a child drowning, a 5-year-old child drowning in one of the gated communities around Pretoria. And he jumped into the water tank. The child was still alive, rushed the child to hospital. And they found that this child needed ICU. They phoned around Tshwane, the whole of Tshwane. In public hospitals, all ICUs are full. They always are, most of the time. And the ICUs in private are usually empty, as you know. And so they had to get a private institution, fortunately, to admit that child. And the child survived. And guess what? They wrote a bill, a huge bill to the mother who happened to be a domestic worker. Something that even a salary of 10 years will never, why do I say 10 years? 100 years. Yes. A salary of 100 years will never pay. That's what they said she should pay. And when she said, no, I'm a domestic worker, they said, that employer who brought the child must then pay because he's the one who brought the child. Well, he was employer. He said, but I did my citizen's duty. I found a child drowning. And I rescued that child. And the only thing to do was to take that child to hospital. What wrong have I committed? So he said, no, I'm not going to pay. Then they wrote to me, you, the minister, you did not provide ICU facilities for this child. Then you are the one who's guilty, you must pay. Because you are supposed to have provided ICU facilities. But we have provided them, they were full. And there's a facility within the borders of the Republic, which is empty. What's wrong with that? I refused to pay. And I said, you can go anywhere. I'm not going to pay a cent. You did what's your civil duty. You know why I refused? And why they didn't go to court? Because Section 27, subsection 3 of the Constitution says no one may be refused emergency medical treatment. Full stop. They don't talk about the status, domestic work, and it's an emergency. So why should we suffer like that? So I said I'm not paying, and the matter died right there. And I can go on and on, giving you these examples because that's what our people live with in our everyday existence. And all these changes, we want to solve that type of problem. Thank you.
No, I just wanted to highlight one issue, especially around mental health, but it cuts across. I mean, we have the public users, stakeholders. Amongst the issues that particular broad stakeholder grouping is dealing with is, issues that affects public users across the board. But the process that we're engaged in now, having submitted our inputs in terms of what we will do as different stakeholders, is to negotiate the dependencies, because no one of us can do what we seek to do without being supported by the others. So I think, as the colleagues have said, part of what we are going to do is to say what it is that we are going to do and how we relate with others in ensuring that we contribute towards, a health system that ensures that the Section 27 is realized.
Thank you. Dr. Akpaka, our country representative from the World Health Organization, could I invite you to just give us some of your observations? Yes, sir.
Okay. No, I'm not. Minister, you're here. No, I passed on the microphone before because I believe that the National Health Summit and the health system is a system for South Africa and for South Africans. We at the World Health Organization stand ready to support not just the government and the public sector, but any of the other stakeholders to move this agenda forward. Be it, for instance, producing a report or supporting development of the compacts or the legislation, we are and will continue to support. Having said that also, I want to tell you a little personal story. My father died because of poor health system. He had surgery, 80-year-old man, abdominal surgery. He had pulmonary embolism, blood clot going to his heart, and he died. That is malpractice. That should not happen to anybody. In 2017, I had a near heart attack. I was flown to South Africa, and I received first-class treatment. And I got well, but then it occurred to me, how many people have that privilege to get that kind of service? My organization might have paid $10,000 or whatever, but because it's expensive here, but that is the right of everybody. And so for us, even me as the head of WHO here, it is to support that approach towards one nation, one health system. That is our commitment. Thank you.
Thank you, Doctor. Okay, I am being intimidated and pressurized in order to take the last comment. Last comment, sir. Microphone.
I'm Khosi Letlape from the Statutory Councils. First comment is the fact that the issue about different voices that need to be heard. Just to remind people that South Africa has been talking about national health for slightly over 90 years. So we started long before the British, the 1929 Laxman Commission. So for how long are we going to keep talking? And there'll always be voices. And in Britain, where they've implemented it 17 years later, there are still voices that were against it in 1948 that are still against it now, and they are being heard, but progress is being made. So I don't think people should think we are all going to agree in this country before something happens. The second issue is that in terms of what is being raised about dumping on the public institution, we must be mindful of Section 27 of the Constitution. Because when those people get dumped, the state can't refuse them. There's an obligation in terms of Section 27 of the Constitution, because when my funds are exhausted, I'm still in a coma, I still constitute a medical emergency. So when the private sector spits me out, the public sector has no choice if it is a part of the republic and respects the Constitution of the country. That emphasizes the point that we've got to make a system that works for all citizens, irrespective of whether they have money or they don't have money. The solution is not, in terms of our Constitution, thinking that you can block them outside. You see, the Americans are different. If you don't have money, you deserve to die in the US. Our Constitution says differently. And we need to act in accordance with our Constitution.
I think those are very powerful, impactful words that capture the spirit of what the Presidential Health Summit is about, and I think the right note to end this briefing. So let me thank the Minister of Health, His Excellency, Dr. Aaron Motsoaledi, for today, one day President. I also want to thank all our panel members, to thank all the health stakeholders who are here today, members of the media, ladies and gentlemen. You are invited to also join us for some coffee. Dr. Shisana is a wonderful host. She went to great lengths to ensure that you have something to eat before you depart. So please don't let her suffer wasteful expenditure. But thank you very much. Thank you, Minister.